I'm here today with Dr. Paul Armstrong, a distinguished university professor at the University of Alberta and chair of the executive committee for the Victoria trial. We just spoke with Dr. Armstrong before regarding the Victoria findings and the ACC virtual sessions, which occurred last weekend. But obviously the biggest headline in healthcare, even then and particularly now, is the current pandemic of COVID-19. And Dr. Armstrong, there's something very interesting that's occurred to me in the past few weeks, being about 50 miles outside of New York City right now, is watching the conversation turn from speaking with cardiovascular experts on the Eastern Seaboard here, talking about how they were learning from their China and Italy colleagues in the time being that the virus was spreading in their country, to now speaking to West Coast physicians about how they're learning from people that are near me about how it's affecting the New York, New Jersey area. Being in Alberta right now, can you tell us exactly what does it look like for you right now? How are you guys staying informed? How are you staying safe up there?
Well, Kevin, the first thing maybe to say is that, of course, one of the things that we treasure in Canada is a universal healthcare system. So we have an integration. It's provincially based. And so in Alberta, there is a single healthcare system that integrates all hospital care and outpatient care. And that allows us to be fairly nimble and systematic in our approach. There aren't private and public hospitals, there are hospitals. And so we're doing our best in terms of learning from the China and European experience. As you would expect with a population the size of the state of New York in a country bigger than yours, that we have more space between our togetherness already in terms of social distancing. But certainly our large urban areas, Edmonton, Calgary, and Vancouver, where it really started in our country, and Toronto and Quebec are all similarly affected. But there are about 10,000 cases now. Mortality seems to be in the 300 to 400 range. We also are, I think, making an effort to do more testing and getting ready. But I think all in all, I would say that we're doing okay in the face of this terrible stress on the healthcare system. That's how I summarize it.
Certainly, and it seems like that's likely the best case scenario we can ask for right now in North America is, sustaining and particularly able to keep space from each other and follow all those public health decrees that I think we all know verbatim at this point. That's great to hear. And you mentioned before, Doc, that University of Alberta is also pursuing some research into the effect of the virus on particular cardiovascular risk patients. Can you highlight a little bit of what's going on right now?
So we actually, Kevin, have a trial that's ongoing internationally. We met as a steering committee. Dr. Frans van der Werf in Brussels and myself are the co-chairs of this. And it's a trial called Stream 2. We did an initial trial which compares a pharmacoinvasive approach with fibrinolysis in the field or at a community hospital, and then a staggered referral for primary PCI if necessary, or rescue PCI versus primary PCI. And as you might expect, the whole emphasis, particularly in the US and in some other European places, is primary PCI. But with a COVID status unknown and the need for protective gear, the access to a interventional laboratory is much more complicated than it was a few months ago. Plus, many of these facilities have been basically decamped to the front line in intensive care to become COVID-centric hospitals, where there is, I think, a focus now on, is there another way? And we think that the early fibrinolysis is a very effective way for reperfusing STEMI patients, and then a more graduated approach to the need for catheterization and intervention thereafter. So that's one thing that we're investigating and obviously very interested in relationship to the COVID status. I guess the other is to say that we're also seeing a dramatic decline in patients with acute coronary syndromes presenting to hospitals. And we don't think the disease has gone away. We think that obviously social isolation and staying at home, it's possible that there's less stressors, although that's arguable in relationship to precipitating a myocardial infarction. The second is, I think that many people are reluctant to call an ambulance when they see the tremendous stressors that are on the system with ambulances running off everywhere, rescuing patients with respiratory failure. And the third is actually fear. About half of patients with acute coronary syndromes are self-presenters to hospital. But of course, the Notion Hospital in April of 2020 is a COVID situation where you might catch something that might hurt you if you were coming in with chest pain and symptoms of a heart attack or a stroke. And so I think getting the message out that obviously hospitals are prepared for this, are concerned about it, and there are ways and means of dealing with it. But I think that would be my observation about the social behaviors associated with, a life-threatening set of diseases and symptoms with heart attack and stroke that we're well attuned to addressing. So, yeah. That's
very unsurprising, honestly, to hear that there's been a decrease in presenting issues in the ICU. It's something that I imagine that's almost inherent from the public health actions taken by so many institutions off the bat. One of the first things we heard about here in the States was the reprioritization of elective surgery, caregivers and everyone else in the hospital relegated to these spots where they were going to be needed even before they were needed. Just anything that considered non-essential was moved to the most absolutely essential priority we can make. Do you imagine this is something that sort of affected the mindset of patients, or is this there, like you said, sort of this inherent fear that if they even are suffering from a condition that may potentially kill them, and again, cardiovascular disease is still the leading cause of death in the world, not COVID-19, do you imagine that they're refraining from care until this blows over in their mind?
I think there's data to suggest that patients are delaying coming in, and we know that there's an old adage that time is muscle and muscle is life. And if you're having a heart attack, the longer you wait, the more likely you're getting myocardial damage. And the worse then the likelihood is that you either get heart dysfunction or heart failure, as we talked about earlier today, or in fact, loss of life. So I think it's a real phenomenon. And I think we have a public health issue here that needs to be addressed. And unfortunately, but recognizably, the COVID crisis has basically swept everything off the landscape in terms of normal behaviors. Yeah.
And what sort of exposure has your colleagues, cardiovascular specialists, cardiologists seen in terms of patient follow-up? How much has telemedicine, telehealth, and prescribing through those measures, boosted, especially in your country right now?
It's remarkable. Yeah, it's unless it's a very urgent situation, we've gone to telemedicine and virtual health, telephone follow-up, and very selective outpatient visiting. So the game has been transformed, no question about it. And we'll see what happens when all of this settles. But I think hopefully the learnings will advance care. Ultimately, we'll learn something useful. And there may be a silver lining. It's just a little hard to see it at this point. Yeah.
Yeah, I think that's the optimist perspective right now, is that the sudden and necessary implementation of telehealth is really going to inform us how we can play a role in everyday healthcare when we go back to normal, whatever normal looks like in the future. Right. So yeah, that is exciting to see exactly how technology is going to sort of bolster healthcare after this, especially in the public health sector. But thinking from another angle of the future of care, with consideration to patients that are holding back, particularly in cardiovascular disease risks that are refraining from seeking care now, are we going to face an issue of overabundance of patients and needs and pressing calls for bolstered therapy after this, do you believe, or are we in a spot that—
Yes, I'm worried about that. I'm worried that the cumulative issue here will take things that were elective or semi-elective and make them more urgent, and I think we'll see a casualty in relationship to morbidity and mortality. But I hope I'm wrong. but it's a conclusion that's almost inescapable at this point, which puts more emphasis on getting through this and keeping the faith relative to our patients. But we'll have to see. Yeah, that's speculation, right? We'll see. Let's hope for the best.
Yeah, absolutely. That's a great sentiment. And are there any other that you'd want to share? Any notes or messages for your colleagues that are at their front line?
Yeah, I think we're in this together, and we recognize that we have a social responsibility to each other, and this is a time to recognize that healthcare professionals deserve our respect, and we need to make sure that they look after themselves so they can look after the rest of us.
Absolutely. That's a great note to end on. Dr. Armstrong, thank you so much for your time and thoughts.
Good to see you, Kevin. Thanks.